Welcome, everyone. We are excited to have Dr. Javier Neyra from the University of Alabama in Birmingham present to us on AKI phenotypes. Dr. Neyra did his initial training in Peru and then his medicine and nephrology training at Detroit and Dallas. He was on faculty at Kentucky for a few years, and then he was recruited to be the David Warnock Endowed Professor at UAB, where he's also the co-director of the Critical Care Nephrology Research at the O'Brien Kidney Research Center. So without further ado, Dr. Neyra.
Thank you very much, and good morning, everybody. It's my pleasure to be here. The talk this morning is going to be about concepts of AKI risk classification and phenotyping. These are my disclosures. And briefly, I'm going to first consolidate some ideas around why AKI is relevant, and it's an area that deserves more study. Then what are concepts of AKI risk classification? And finally, a little bit about subphenotypes of AKI that we should recognize and how we can continue this work that is work in progress. So as you guys know, AKI is a frequent problem in the hospital. Approximately 20% of the patients develop acute kidney injury. Of course, if you are in the ICU, these incidents go up to about 50%. Some of these patients will develop acute kidney disease, which has been recently defined as the persistence of AKI beyond 7 days, and in this window of 90 days from AKI onset. About 1 of 4 patients will develop acute kidney disease in this period of 90 days. And then subsequently, survivors in the subsequent 5 years, they will develop chronic kidney disease. Some of them, approximately 1 of 3 patients will develop these complications. Now, as you know, patients with acute kidney injury and subsequent complications, a lot of the time, their main problem is not the kidney disease per se, but cardiovascular disease. That's the most common cause of death, and also the cause of multiple problems in these patients, including rehospitalizations. And that it's something that's why it's very important, the cardioprotective interventions in this population. When you look data 10 years ago, and unfortunately it has not changed very much, when survivors of AKI, particularly vulnerable populations, in this case, patients above 66 years of age, half of them will go home, but there is a fraction, a good portion of them, 1/3, that will go to nursing homes or LTAC. So this type of rehabilitation facilities that patients still need after discharge from the hospital from an episode of AKI. And by this time, less than 10% of AKI survivors have guideline-based follow-up after discharge. That pretty much says within the first 3 months, this patient need to have an evaluation with a check of creatinine and proteinuria and a visit with a clinician. So less than 10%. This has not changed much, as I said. In recent data, this can go up to 20, 30%, but that's it. So we definitely have areas for improvement, both in the hospital care of AKI and also after discharge. Another important aspect that is always under-recognized is that survivors of acute kidney injury always have physical function limitations, and also this translates into low scores of quality of life. So in this study, from our group, we evaluated patients with survivors of stage 2 or 3 AKI and patients without AKI or AKI stage 1. We grouped them like that. And you can see the results of the 6-minute walk in the treadmill, much more limited in patients with severe AKI. And this was evaluated approximately within 3 months after discharge. And this translated also in lower scores of quality of life on the bottom, very significant impact on return to work and hobby, and even return to driving for those patients that previously were driving before hospitalization. This is the graphic representation of that. So on the left side is the distance walk on the treadmill, and you can see that the predicted for that patient age and sex is much higher than these patients achieve. And there seems to be a dose-response relationship according to the severity of the AKI. So we concluded here that survivors of critical illness and AKI stage 2 or 3 have increased physical debility and overall lower quality of life, with more impairment in return to work, hobby, and driving when compared with patients without AKI or AKI stage 1. In a different study from a different group, they evaluated these domains of quality of life, that is immobility, pain, cognition, and assisted care. And they concluded that over 1 in 4 patients reported health states equivalent to or worse than death. Now, the kidney after injury needs to repair, and as you guys recognize, there is an adaptive repair that at multiple levels affect the tubular proliferation, endothelial regeneration, mitophagy, the switch between cells, particularly fibroblasts, macrophages, and resolution of inflammation. When this process is affected at any level, it's going to happen what we call maladaptive repair. So then, a consequence of this is that some patients will recover and some patients will recover partially. Some patients are more susceptible to recurrent AKI. Some patients will transition to acute kidney disease, and then the complication of chronic kidney disease that I mentioned before. So, of course, in this milieu of conditions, a risk classification tool may be helpful. How we do it currently, we evaluate prognostic factors in patients. For example, on the top of the slide, you can see clinical parameters that we pay attention to: the AKI severity based on the KDIGO score, the duration of the AKI, the level of kidney recovery, the category of acute kidney disease, if you like to use that classification, and of course, some surrogates of residual renal reserve that can help us identify how that kidney is going to respond to stress. Simple things, when we evaluate a patient after discharge in the terms of creatinine recovery from the baseline, if we have a predefined baseline. In this particular study that we did a few years ago, we determined that when your creatinine in the first window of 90 days after discharge is still 50% above your baseline, as you can see in the red line there, there is a significant risk of developing chronic kidney disease in the subsequent 3 to 5 years. And this seems to be those response related to the level of recovery of kidney function in this window of 90 days. Similar study, this is from Morgan Ramsey, Hopkins. You can see that when you evaluate the recovery of GFR around 30 days, 60 days, and 90 days, and if this drop in GFR in reference to baseline is in this window that we call 20 to 40% drop, if you want to use a simple number, you can use the 30% drop. You can see the hazard ratios of the association between this drop in GFR after AKI with the development of end-stage kidney disease, hazard ratios that fluctuate between 5 and 7. So very significant risk when you evaluate a patient in this window and you have still a drop in GFR significant from baseline. This all carries economic consequences. As you can see on the left side on the slide, we have the increased cost. This is based on US data, AKI care, because of the prolonged stay in the hospital, sometimes in the ICU. This convey costs between 5.4 and 24 billion. Even patients, the smaller group of patients that develop AKI requiring dialysis, despite their lowering number, they also carry about a 5 billion burden in economic consequences. So with that, I hope I convey the message that AKI, it's a relevant condition, and I give you some angles where you can improve your care beyond your initial recognition of these patients in the hospital. Now, when we talk about risk classification of AKI, we can organize ourselves according to the timeline, the continuum of AKI. So we can risk classify a patient with AKI before AKI occurs, ideally. A lot of the time not possible. We can risk classify a patient early during the course of AKI to prevent progression and or complications. And also we can stratify a patient after AKI to prevent the recurrence, rehospitalization, that is a very important problem in these patients. And of course, the transition to chronic kidney disease and cardiovascular disease, as I mentioned before. So this is a very popular slide because the kidney is graded in colors from normal to a dead kidney. And with this help us to recognize in this timeline the window for potential intervention. So in the past, our goal was to recognize AKI early with early signals of damage, of injury or stress, to perhaps implement interventions that can mitigate the progression of AKI. But now also we have interest in identifying patients at increased risk. And not only that, identify patients that according to the potential response to stress. And of course, as you imagine, to respond to stress, two factors play a key role. You have the reserve capacity of your kidney and also the adaptation capacity to stress of your kidneys. So perhaps in addition to recognizing markers of early damage in the kidney, the ability to recognize kidneys that have or that will have worse adaptation to stress or less capacity to adapt to stress may help us to risk stratify patients before even they are exposed to these stressors. So in this realm, biomarkers are helpful. Unfortunately, implementation of biomarkers have been very slow, and we recognize collectively that we need to start using real-world data and more implementation data studies to be able to really guide the community into how to use them. We have a lot of biomarkers with potential use, but very few of them, if any, are being used routinely in clinical care. Now, simple, you can, when you, for the fellows on the call, when you go later to evaluate patients in the hospital, you can identify susceptibilities of the patients to AKI, some of them non-modifiable, like characteristics of the patients like the age, the status of chronic kidney disease and certain comorbidities, and also modifiable risk factors, most of the time according to the drugs these patients are exposed to. And then we identify the exposure. Some of them are planned, like patients are going to go for elective surgeries, and some of them are unplanned. Patients have a level of infection or level of a condition that is affecting their intravascular volume, and this can be reverted with interventions, right? So we can map a little bit how to address the risk of a patient doing this simple exercise. Now, of course, can we create risk scores that can help us identify patients at higher risk of developing AKI? This concept, as you can see the date of this manuscript summarizing some post-operative cardiac surgery AKI risk scores, was more than 10 years ago. And the famous scores, Cleveland Clinic score, the META score, SRI score, typically use certain variables related to the patient characteristics like age, race, sex, the preoperative level of kidney function, the level of heart failure, and some characteristics of the surgery that the patients are going to be exposed to. Of course, this was more helpful for patients undergoing elective surgeries, but have a certain ability to classify risk in these patients. Now, the performance of those scores, of course, when you started to validate them externally, dropped because they were developing very unique populations. Now, the field moved a little bit from a static score completely preoperatively that you can evaluate in a preoperative visit to using more dynamic data, right? So this is from Cleveland Clinic also, that where the initial score was developed. But here, in addition to certain characteristics of the patient, they evaluated the change in creatinine perioperatively. So starting to use semi-static scores with different metrics of creatinine response to the stress of the cardiac surgery, in addition to other biochemical parameters that you can see there, like BUN, potassium, sodium bicarbonate. And with these, they obtained very good AUCs of 8.6, 0.86, and 0.9 that for the prediction of post-cardiac surgery AKI between 3 and 14 days subsequent to the surgery. Of course, this is single center data with a little bit of external validation, but promising in the fact that when you use dynamic data, even in a semi-static score, performance can start getting better. And this is another example of semi-static data we did. You probably remember the renal angina index in children. We did a modification of this for adults in two cohorts, University of Kentucky and University of Texas Southwestern. A good number of patients there, so development and external validation. We modified this score according to certain parameters in the logistic regression that were significant for the association of the characteristics of the patient in the first day of ICU admission and the risk of developing severe acute kidney injury defined as a stage 2 or 3 AKI in day 2 to 7 during that hospitalization. These parameters were diabetes, the presence of sepsis on admission, the presence of mechanical ventilation, or the use of vasoactive drugs like pressor inotropes. A little bit, again, the semi-static component, the change in creatinine during this first day of ICU admission, and the level of fluid overload of these patients. So with this, we obtain decent, not extraordinary performance with AUCs that fluctuated between 0.78 and 0.76 in the external validation cohort. Definitely a little bit better than just using your creatinine change alone to predict the progression or the development of severe AKI later on. Now, in this context, now we have better tools. We have machine learning tools, artificial intelligence solutions that can help us move the field a little bit forward in the field of risk stratification from what we do right now, that we have, for example, our evaluation of the patient depends on some of the data is collected in the electronic health record, if we happen to have an electronic health record. But we do it very sporadic, right? You are going to go to round today, and you're going to evaluate the data that is available as of now. A lot of the time, you will have incomplete data points, and certainly your evaluation is not linear, not integrated into a clinical workflow. Sometimes you need to reassess certain patients that need extra help during the day. And this is how we make decisions. Now, but with the use of biomedical informatic tools and artificial intelligence, we can integrate different data sources, particularly not only from the EHR, but also from the imaging data we generate, the monitor data that contains a lot of dynamic real-time data, and certainly data from the devices. The devices we use in the ICU, particularly the ventilator, the dialysis device, and other extracorporeal organ support devices, collect a lot of data that we can integrate and use in risk classification to enhance, augment our ability to make decisions in a dynamic way using multimodal sources of data and more integrated into our clinical workflow with the use of clinical decision support tools. Now, some examples of machine learning for AKI prediction. This is a study from Europe, and they use the EPANIC data set. This is a study on nutrition interventions in the ICU. They use 2,000 patients for development, similar number for validation, and they evaluated data in the first day of ICU admission to evaluate the occurrence of AKI subsequently from day 2 to day 7. You can see certain parameters included in this model, baseline characteristics of the patient, so static parameters, and also some dynamic parameters that the change in serum creatinine from day 1 to day 2, or day 1 and day 1 plus, that is the subsequent 24 hours, and the certain biochemical parameters as well as hemodynamic data as expected, including some scores like the Apache 2. And you can see with this data input in the model, the prediction for a stage 1 or more AKI in the subsequent day 2 to 7 was 0.75 in the AUC, and to predict severe AKI, the model performed even better, 0.83. Was compared to ENGAL, because this cohort happened to have ENGAL measurements, and outperformed the prediction of ENGAL a little bit. ENGAL was 0.79. So Marine Flechet was able also to compare this tool, this risk classification tool, with what the clinicians will predict with the same data, points of evaluation during the same window of time. In a subsequent study, of 529 patients, where the model was compared to what the clinicians will predict. And as you can see, the risk score outperformed clinicians at the time of ICU admission. With that data available at that time, the model performed 0.8 versus 0.75 the clinicians. And using data up to day 1, so a semi-static score, 0.94 versus 0.89. And the physicians typically overestimated the risk of developing AKI. That was a little bit the difference between the two models of comparison. Now, this is the famous study from the VA, collaboration with Google and DeepMind, about 700,000 patients. Of course, VA data, limited gender diversity, and many features were used from the electronic health record data, completely automated collection of these features. The idea was to have, for the first time, a dynamic model that was rolling throughout the hospitalization with more data input to predict in different windows of time, as you can see in the table, 24, 48 hours, and 72 hours, the occurrence of acute kidney injury, either any AKI or severe AKI stage 2 or 3 or above, yes, only 3. As you can see, this model had a very good performance, and for this rolling dynamic risk prediction, and it was very encouraging. Despite this may not represent your population and may not be applicable in every electronic health record, it proved the concept that dynamic risk prediction can have very good performance, and therefore as a potential solution to identify patients at high risk. Another example, this was from University of Chicago, ICU data. Again, as you can see in this table, very small, but multiple features that were evaluated for a model input from patient demographics, characteristics that are hemodynamic, biochemical characteristics, etc., to predict from data in the first 2 days of ICU admission to predict the occurrence of AKI in the subsequent 24 or 48 hours. And you can see from all the encounters that were evaluated, the performance of this prediction using this input in the model fluctuated from 0.93 to 0.97 for severe AKI stage 3 or just dialysis requiring AKI. That was a very good performance from this study using these dynamic data points that including some characteristics of the patient, but also some rolling of certain characteristics, particularly hemodynamic characteristics and biochemical characteristics that were relevant. This model was externally validated and had maintained some good performance. And I know this group is working now on implementing these with some actionable interventions to try to see if we can mitigate the incidence of particularly severe AKI or dialysis requiring AKI, right? So because you can say you can have a very good model, now can you show that you can intervene in a reasonable time frame to mitigate the progression or the occurrence of AKI? That's kind of the goal of these studies. So one more example, this is from our group, different to the prior studies that their goal was to predict acute kidney injury. Here we wanted to predict major adverse kidney events in patients already having creatinine and urinary output definition of acute kidney injuries are all in ICU patients. So that was the goal of this risk classification tool. We use different predictors, similar to other studies, characteristics of the patient, characteristics hemodynamics of the patient, biochemical parameters, and a lot of features also from the ventilators when the patients were on ventilators. The mortality, we used 2 cohorts, University of Kentucky, UT Southwestern. Mortality, that was one of the outcomes of the model, occurred like 21% in Kentucky, close to 10% in Dallas. And the incidence of major adverse kidney events at 90 days was between 25 and 30% in both sides. So this is very consistent with literature in ICU data sets. We use 4 machine learning algorithms and a SHAP framework to identify or to try to interpret the model output, and we evaluated the performance with internal cross-validation, and also the Dallas cohort served for external validation of these models. So we use different machine learning classifications from logistic regression going to XGBoost, and the initial input of features were 71 features that were selected, and then we classify based on these tools the top 15 features. We wanted to create something feasible, not a model that the only way to implement it is with a lot of computing capacity. So this is just a model that we'll use based on the interpretation that we did on the machine learning models and our clinical rationale on 15 features for mortality prediction and 14 features for MAKE. And then we move to the interpretation. This is very common if you guys are reading recently a lot of machine learning, AI studies. You will see a lot of the models report the SHAP visualization that help you to evaluate each parameter for the relevance for the model and also in which direction, right? So for example, if we take the example of the top performer there, that is the KDIGO score, in this particular study, we use the window of the first 3 days of ICU admission to predict the outcome of MAKE and hospital mortality at 90 days. And one of the most relevant features was the level of severity based on KDIGO of the AKI. These are all patients with AKI already. So the higher the severity of the AKI, the higher the score and the higher the relevance also for the model in terms of prediction of major adverse kidney events at 90 days, which makes sense, right? It's not surprising for us clinicians that the severity of AKI is relevant for the prediction, but that's most of the time the only thing we use to classify a patient. Now, there are other features also relevant, the urinary output in that window, the level of oxygenation, vasopressor support, and other biochemical parameters. So therefore, a model like this can help you a little bit better in risk classifying a patient. So the mortality and the MAKE incidence, and according to what the model predicted and what exactly happened, and this translates into performance that are decent, not great. In my opinion, these models are not going to be exchange of your clinical decision capacity, but are going to enhance your ability to identify a patient as high risk that perhaps clinically you will consider it's low risk. So as you can see, a lot of the value of these models is in the negative predictive value. The AUC of performance fluctuate from 0.79 in development cohorts drop to 0.75 in validation cohorts. So these are good, but not great, but perhaps enough to help us make decisions, particularly if I give you a prediction of MAKE to determine how you're going to follow those patients in the subsequent month after discharge, which is very relevant for the intervention. Very simple to input, and we have a web page to deploy these. You can try, you can play with it, and we're still refining those type of work. Again, as I said, it's not the model itself, it's what we do with the model. So I think if any of the trainees in the call is very excited about AI, machine learning, the most important aspect is not only to develop good models, but also how we're going to use them. And I think we need to, if you are a computer scientist or data scientist, you need to develop skills in implementation science, because that's the only way that we can prove that a model works. Now, if we go to more examples of dynamic risk prediction, this is another case scenario, right? The patients that are requiring continuous support with dialysis, in this case, CRRT. In the left side of the panel, we use a MIMICS-4 data set to identify a dynamic risk prediction of mortality. You know, these patients have high risk of mortality. But you can see with a dynamic risk prediction, in this case, we use LSTM and MLP. You can see the inflection point when this is an individual patient, the probability of mortality significantly increased at that time point with the cross-sectional line in red, approximately 48 hours before the patient died. So you can argue, is there enough actionable window? You may say yes, because sometimes in a patient that has very poor prognosis, the intervention is actually not to do much. It's to provide that patient quality of death and try to be less invasive and more realistic in the conversation with the family. So that could be the intervention, and that has a lot of impact in critical illness. Of course, we would love to have interventions, or sometimes for some patients do something that change the outcome of death, but that could be difficult, particularly for these high acuity populations. And this is another example with different data set where you can see in individuals where that survive, the model is able to continuously predict that the patient has high chances of surviving, so the risk of death is decreasing, versus patients that died, the model is able to classify the risk of mortality going up in patients that effectively died. So some other examples of risk classification. Now, be careful here. Again, the AUC of these models fluctuates between 0.75 to 0.8, are good but not great. This is the challenge, that to really create good quality models, you need to use harmonized data sets. And these are not widely available. And a lot of the time, maybe 50% of the time, you will see that people is using from all over the world for ICU predictions, mimics data sets, or the EICU as well, that is being used more frequently now. But because these are data that has good harmonization process, but having external data sets that are well harmonized is very challenging. Now, yes, we want to use the most advanced deep learning algorithms for the model predictions, but the most important thing is the external validation, the account for biases, and the implementation testing of these tools, as I said earlier. That's where the challenge is, and I want you to be challenged by this statement. Now, positive notes. Yes, there are many models I show you are good but not great. Some maybe even close to great, but we need to show how we can use them. Now, despite I don't want to show you any particular trial on a specific model, I will show you examples that risk classification can have an impact on AKI. This is a small study, single center, the Pribaki trial, that then had a subsequent multi-center version that show very similar results. But this was just risk classifying patients after cardiac surgery based on the cell cycle arrest biomarker TIM2 IGF-BP7. If it's positive, the patients were considered high risk of developing post-operative AKI. They were randomized to an intervention that included a dedicated team that will carry out the KDIGO recommendations to mitigate AKI risk, as you can see on the left side of the slide, versus the standard of care. And you can see that identifying patients high risk and having a dedicated team to mitigate AKI decreased the AKI incidence postoperatively from 71% to 55%, and severe AKI, so stage 2 and 3, from 44% to 29%. So this is reassuring that we can intervene. In the multi-center subsequent study, only the mitigation of severe AKI was shown effective, and not of all AKI. But that's still encouraging, because severe AKI is probably our target to minimize. This is another interesting example. This is not a clinical trial, it's a prospective study that they use what is called the AKI SCAMP, that is a clinical decision support tool, not sophisticated, very simple on paper. And this was done in a study in Boston to help the patients make decisions about initiation of RRT in a more structured way with the CDSS and in versus the control. And you can see the study compare two arms, although this was not randomized, for different outcomes in patients that were in evaluation for RRT. And the outcome that captured my attention, that I think is always underestimated, was the outcome of the reduced use of RRT when the physician perceived the treatment is going to be futile. So that was a statistically significant difference between the two groups, which is important, because if you see the epidemiology of patients with AKI requiring RRT, particularly in the ICU, there is a group of patients with early mortality in the first 24, 48 hours, that a lot of them, and that fluctuates around 10 to 12% of patients that have this phenotype. You can argue how many of those maybe we should not have even offered RRT because of the poor prognosis. So this study showed that interventions around helping in your decision capacity can mitigate the futility of providing the treatment. Another example on a positive note, I'm going to first focus on the right side of the slide. This is the study from Perry Wilson's group where they evaluated the alert of identifying AKI patients and a CDSS embedded on it to help patients manage certain medications. As you can see, the alert and the CDSS help clinicians to stop more RAS inhibitors and also PPIs, not that much for NSAIDs. So that means clinicians are already good to stop NSAIDs in patients with AKI, but not too good for PPIs and RAS inhibitors. And you may argue not in every patient we need to stop RAS inhibitors anyway, right? So on the left side of the slide, it evaluated the outcome of the trial. The trial outcome was the progression of AKI to severe stages requiring RRT, etc. And you can see that in the subgroup on the right that had the PPI stop, there was a significant decrease in the composite outcome of progression of AKI, right? So that's on the right side of the left panel, and which is encouraging, right? So the alert and the CDSS help the clinicians to stop more PPIs, and when that happened, there was an impact on the progression of AKI, which it's a good area of intervention because it's not too far that we start to recognize the potential nephrotoxic effect of PPIs in the context of AKI. And we use them freely, now less than before, but a lot of people don't pay attention to PPIs for sure. Finally, the post-AKI risk stratification. As I said, when you are going to determine, now you're signing off a couple of patients with AKI, you will determine your recommendations on follow-up based on the level of CKD, the severity of the AKI, and the level of recovery of AKI on that patient, very likely, when you're trying to phenotype AKI. But eventually, when we incorporate these risk classification tools to help you make your decisions, you can identify patients with high risk that may need to be seen early and perhaps by nephrologists, and patients with intermediate risk where you can have that follow-up in the first 4-12 weeks after discharge. This will also help patients eligible for some interventions after discharge. I told you earlier in this talk, there's a lot to do with these patients, and we need more clinical trials in post-AKI interventions. So this is how we should aim to practice in the near future if we're not already doing it with incorporating these classification models into our clinical practice. Now, in the last 10 minutes, I'm going to touch a little bit on concepts on subphenotyping. This is a nice slide summarizing 2 levels of phenotypes, right? On the top of the slide is the prognostic enrichment of the subphenotype. What this means that the subphenotype tries to identify a subset of patients at high risk for an outcome of interest. Let's say we want to identify patients that with AKI that will require renal replacement therapy. That is the prognostic enrichment of the subphenotype, a subphenotype of AKI reaching the ICU with high risk. Now, the most important subphenotype, and that's where our focus is as a community, is the predictive enrichment. This is a subphenotype that is going to identify a subset of patients likely to respond to specific therapies due to a common underlying biology. And this is where therapeutic development could be certainly enhanced. Imagine you're working on a drug that is going to mitigate inflammation in AKI. That is one of the big components of the pathobiology. And you have a way to enrich those patients to identify the subphenotype of hyperinflammation with AKI. So those are the patients you want to try to enroll in a clinical trial testing this drug, and hopefully in the future treat them with this drug if the drug is effective. Now, it's complex because AKI has multiple etiologies, and the etiology affect the subphenotype. And in this particular example, it's represented the subphenotype of the trajectory. You have a patient, just to put 2 examples, with in the letter A in blue there, that is clearly hypovolemic, and that's the cause of the AKI. And when you restore the intravascular volume, the AKI resolves, right? The creatinine is on the y-axis here, and on the x-axis is time. And you have patients, let's say in red, with hepatorenal syndrome when you have a persistence of severe AKI, that if the patient has really HRS AKI type 1, you will need to offer these patients a transplant for them really to able to recover that AKI. Now, multiple phenotypes based on etiology. Now, the other interesting thing is if we want to biologically phenotype this predictive enrichment, these always capture my attention. I know this is a busy slide, but represents a lot of the processes in the pathobiology of sepsis AKI on the left side, and on the right side. And sepsis AKI, of course, you recognize endothelial damage, epithelial damage, inflammation, and a lot of this related to the interaction between the host and the bacteria, if it's a bacterial infection. But when in clinical trials of sepsis, of course, a lot of those patients developing AKI, they have tried to identify, using latent class analysis, variables that can differentiate the type of AKI. And they with this latent class analysis, they found two subphenotypes, SP1 and SP2, very different. You see all these parameters that play a role, some biomarkers that were available from the trials, some characteristics of the patient. But the lesson of this work is that the patterns of biomarkers reflecting inflammation and endothelial injury, a lot of the time the IL-6, IL-8, the PI1, have also underpinned a subphenotype of hyperinflammation that associates with increased mortality in ARDS. So what does it mean? So when the ARDS field start to develop their latent class analysis to identify subphenotypes of ARDS, they come up with this differentiation of hyperinflammation that is the same differentiation that these two subphenotypes of sepsis AKI came up with. That means that perhaps we need to start thinking patients that are acutely ill with multi-organ damage. There is not a single phenotype according to specific organ injury, but there may be a global critical illness subphenotype that may help us integrate not only the interventions for mitigating damage, but also to promote recovery, and in a more orchestrated way where organ crosstalk plays a role, right? And you have seen a lot of talks about organ crosstalk, and it's at the end, there are common pathways that can be subphenotyped similarly in different episodes, in different conditions that sometimes occur at the same time. Subphenotypes based on level of recovery, very important. In the left side of the slide is the conceptual representation of different trajectories of AKI that you see a lot of the time in the hospital. On the right side of the slide is the support by data that when you classify AKI based on the duration, from early sustained reversal to never reverse, there is an important dose-response relationship with the adjusted survival function in terms of the follow-up up to 1 year following the AKI episode. So this is very important. So we already have a lot of information with the trajectory of the AKI that can help us subphenotype our patients. And my last comment is based on this. So when we did this study during COVID, we had the chance to evaluate a filter that is Oxiris that provides additional hemoabsorption. So the Oxiris has an extra layer that is coated with heparin that helps to remove a little bit more solutes, particularly inflammatory solutes, that based on this enhanced hemoabsorption capacity. And you can see the ability that we had in our group to evaluate machine data allow us to generate these figures when you can compare the transmembrane pressure on the y-axis and time on the x-axis between the Oxiris filter and the control. A filter with enhanced hemoabsorption, so solutes sticking to the filter, has a higher transmembrane pressure comparing to the standard filter we were using that was HF 1400. This is observational study, not a randomized clinical trial, but this is not surprising, right? But this is what we see when we try to phenotype or to evaluate two interventions. But then when you evaluate this trend of the Oxiris filter in the terms of treatment effect, and you can say how heterogeneous is this trend according to patient level data, this is what happens. So Not every patient has an elevation in transmembrane pressure. That means that there is not every patient, the filter is sticking to solutes that perhaps are important to remove or not. So if you evaluate this in a patient individual level, you can create an enrichment-based phenotype. And that certainly can help for adaptive trial design if you have tools to evaluate response to treatment, or at least in this particular example, the hemoabsorption capacity, right? So this is how we're going to practice in the future when we evaluate treatments in very heterogeneous populations like ICU patients. We need to have ways to evaluate treatment effect, and particularly the heterogeneity of treatment effect. So to summarize, so you guys can go to round, you at this stage, you may not have an AI/ML tool embedded in your EHR, but you are very competent to evaluate patient-specific susceptibilities and also recent or active exposures to classify risk of AKI. So you can identify yourself patients at low risk, intermediate risk, high risk. If based on the classification of susceptibilities and exposures, you have patients you consider intermediate risk or high risk, those are patients you can use biomarkers that are FDA approved, like the cell cycle arrest biomarkers if you have them, or the urine engulf for pediatrics if you have them. But if you don't have the biomarkers, you can use a stress test like furosemide response, if the patient, of course, is not hypovolemic. That will help you to identify these patients where you will have a more iterative monitoring of creatinine and urine output, and also try to be more aggressive with your guideline-based intervention to minimize risk, mitigate, and hopefully revert AKI. So you can do some of these. I'm sure you are doing it, but it's how you can create this risk phenotype practice a little bit more effective, more sustainable, and more standardizable is what we need to work together on. A lot of input in the future that can help the subphenotyping of patients. This goes from static parameters of characteristics of the patient to dynamic parameters that I show you in multiple models today, biochemical data, hemodynamic data, multiple dynamic data that we can obtain from the multimodal sources, including the EHR, the pathobiological signals. I talk a little bit about some biomarkers of inflammation in the case of sepsis AKI, for example, response to treatment. And then don't forget the bottom of this slide, that is the genetic predisposition of the patients when we start incorporating more genetic variants into our day-to-day practice. Social determinants of health are very important for kidney disease, have been not very well studied in AKI, but now there are studies coming suggesting that these are important factors to consider in the subphenotyping of these patients. And of course, we need to evaluate the specific outcomes that are not only clinical, but patient-centered outcomes for the subphenotyping classification. So with this, if we integrate all these, we can have perhaps better ways to risk classify, subphenotype these patients. And we can also have better ways to develop pragmatic and adaptive clinical trials or platform trials that are going to be helpful for AKI research, where we need more therapies, right? We need really therapeutic interventions beyond our KDIGO band. With that, I'm going to finish, let you guys some time for questions. I, again, want to thank, of course, a lot of members of my team and collaborators, and your kind time to listen to me this morning. Thank you.
Perfect. Thanks. Perfect. Thanks, Dr. Neyra, for that wonderful overview of the topic, and you have a great body of research in this area. I really like the etiology, AKI, sub-phenotyping, right? Because all AKI is not the same. So if people have questions, please raise your hand and I'll call upon you to ask and speak up. Dr. Clark.
Thanks, Javier. I just, one thing I wanted to just ask you a bit more about that you touched on is, you know, the argument that we should be using more biomarkers to get sort of more real world data about how they work. But I'm always a bit skeptical about that argument because it doesn't really fit with anything else we do in terms of like I'd like to see the large convincing trial showing an improvement in outcomes before we do that, especially when we have other options, like, furosemide stress test.
That's a great point.
Are you using it now in your clinical practice?
We're not. We don't use cell cycle arrest biomarkers. We don't use NGAL that in the pediatric, our neighbor across the street. Those are the two right now that you would say are FDA approved for us to use. But we don't. And exactly for what you said, that there is lack of implementation, science, evidence. How are best practices to use it, right? And can this be effective in mitigating AKI risk? And also, do we have enough ways to intervene based on the output of these biomarkers? So if you were to have a biomarker that you just discovered, and you come to me and say, hey, Javier, we need to work on biomarkers have a lack of implementation in the AKI field, so how we can create ways to overcome this. I would say we need to have a biomarker that can be measured very, very fast and easily and in the central lab, right? So having biomarkers that you measure separately, very difficult to implement. And then we need to generate what you just mentioned, real world data. And you're right to be a skeptic because nobody has proved this, but I'm right now doing a consultation for your new biomarker. And I tell you, let's develop real world data. So let's measure it sequentially for 6 months in all ICU patients. Let's identify what are the phenotypes the biomarker can help identify in terms of risk of AKI. And they'll say, okay, maybe in these particular subpopulations, the biomarker can be effective. And effective this way, maybe early recognition, enough to intervene. And then we develop a study to prove that, right? An implementation science study where with the signal of the biomarker, we will have an intervention and then show what we don't know yet, that you are right. We don't know if a particular biomarker signal can help improve our practice. So, and you mentioned it right. That's why in my slide was, if you don't have the biomarkers, you have a very good functional test that is the furosemide stress test to risk classify the level of perfusion to your kidney and the level of tubular function that can give you good insight about how well that kidney can respond to the ongoing stress, and you can make decisions according to that. We use it every day on real practice. We just had some friends that decided to make it a furosemide stress test and in a more formal way, but that's exactly right what you said.
Thanks. Just if I can just ask one other, it's not it wasn't central to your talk, but just you did mention about like PPI discontinuation. And it's something that I don't think we do routinely. And I'm just wondering what the, like, obviously there's that study, but like how solid is the evidence overall? Because that's a very, it's hard to do that in a blanket way. Like there's some risks involved in doing that. Agree.
Yeah. So PPI is probably now what we consider in the past when we were using NaCl 0.9% very freely, that this don't hurt anybody. Now we recognize, okay, high chloride solutions may have some impact in certain patients. Now PPI, we also, every patient in the hospital needs some prophylaxis because it's a lot of stress. We need to protect them from developing peptic ulcers. So I think that's an area that even with contemporary data that I show you with Perry's trial, there is the clinicians just an alert and telling them PPIs probably you should consider stopping. There is an effective intervention to stop them. I all the time when I run with the fellows, that's one of the medication we take a look at if the patient really needs it. Yes, you can have a patient maybe coming with a GI bleed. The patient needs the PPI not only once a day, twice a day. That's a reasonable explanation. Or a patient that really have a history of a very bad peptic ulcer disease or gastropathy that they take chronically PPIs, and during the stress of the hospitalization, you need to continue it. But a lot of the times, I would say maybe in at least 2/3 of the time, the PPIs are just part of the combo we give the patients in the hospital. And I think that's an area that is potentially a room for intervention. And as you can see in this particular study, this subset is a subset of patients. So we need to take this data still with a little bit of caution. there was an improvement in the composite outcome of progression. So I will encourage the trainees on the room to really evaluate if the patient has indications for a PPI, and if not, in a patient high risk for AKI or with early AKI, try to stop it. And also keep in mind, even if you don't see it in the hospital or they stop it because you have a clinician that is very up to date, a lot of these patients go back home and they have a PPI in their medication list, and they will start taking it because, oh, that's my PPI to protect my stomach, and not telling anybody. They start taking it again. So now that we're doing a study with post-AKI survivors, we have a lot of the time, oh, where did you get that? Oh, I had it from before. Okay, so perhaps you should stop taking that as well. You don't have a clear indication. And you just do a trial, right? Some patients are very attached to it. Just do a trial for a few weeks, how they do it. And if you tell, if you're not doing well, we're going to put it back. But if a lot of the time they tolerate it and they forget that they need to take PPI. So that's a very important area for implementation science. So if the fellows want to develop a project with ET and SWAP, that's a good project to consider.
Thanks, Javier.
Thanks.
Yeah, I think Manish has his hand up, and then we have a question in the chat. Manish, why don't you go first?
Thank you for that very, very interesting and excellent talk. I tip my hat to anyone who is willing to take on AKI research, so you and Ted, because it's very difficult to study. My comment is a comment more along the lines of what Swapnil said and what Ted said. I'm old enough to remember when we stopped phenotyping pre-renal, renal, and post-renal and amalgamated it all into AKI, and Glenn Chertow's paper came out that showed 0.3 milligram per deciliter rise in creatinine is universally bad. And at the time, we kind of went to any AKI, rise in creatinine is bad. And now you've shown some of the data, especially with the dynamic prediction models, that if you go past 24 to 48 hours, the prediction improves. And that's because the pre-renal is being ruled out. And often the pre-renal is a marker of health. You see that, for example, in runners. They develop pre-renal and tubular injury with biomarkers, but then they do well overall. And we've also shown that previously. I was involved in a study where we showed that with sepsis, early reversal is a good sign. One more point, recently, we were at a cardiorenal conference, and some of the data emerging from heart failure shows that if you decongest the patient, they develop worsening renal failure, they do better renally in the long run. So again, that's kind of an amazing one. I'm happy to see the return to sub-phenotyping. It took maybe a decade, but that I think is the key. And the one piece is that I was going to add is I don't think there's enough studies, it's hard to do epidemiologically, showing or teasing out these phenotypes and outcomes. And the reason I say it is, right now we clump everybody into AKI risk from presentation. Very few studies look at reversal within 24 to 48 hours. And what that does is it doesn't disentangle the healthy ones who are pre-renal in reverse, and it underestimates outcome risk in all the others who do not. And I think we're seeing it with the prediction models. We may not be seeing it with enough epidemiologic evidence. Anyway, that's just my comment. Great work. Thank you.
Yeah, thank you, Manish. Yeah, no, great points. Yeah, you're right. So if you pay attention to those models that I show, the prediction improve in the window of 48 hours, and the models like a lot what's the trajectory of the creatinine in those 48 hours. So what Manish was saying makes a lot of sense. Like it's the model is really valuing a lot the reversal and the exclusion a lot of the times of those patients that have a pre-renal AKI. And yeah, and also like what exactly the creatinine worsening means in a heart failure patient, right? So perhaps you can have heart failure patients are chronically debilitated patients, and a lot of the times they may not have enough muscle mass mount a creatinine response. So perhaps those when we see this decongestion increase a little bit of creatinine means that they are patients that are fit, that still have some muscle mass, that still are active somehow, versus patients that are more debilitated. So it will be nice to see how this relates to the statin C2, for example, right? If it follows the same trajectory or not. But yeah, so I think that's a very nice remarks from Manish that are very helpful and encouraging for everybody to pursue more research in AKI. So you need to be adventurous to do AKI research.
If you have time, I know we are slightly over time, but there's a question in the chat from Mark. It's a wonky question, so I left it for the end. So he's asking about your dynamic predictors in the ICU use. He's saying that they use the slope of a continuous exposure. And he's asking that this would suggest that the exposure is captured after admission, but prior to the time at risk.
Yeah.
So are these dynamic variables time varying, or are they defined prior to time zero?
Yeah, that's a good question. So in the model that we developed, we use the first 3 days of ICU admission. So ICU admission was the time zero of the window of prediction, and day 3 was the end of the window of prediction. So we use all that data dynamically to predict the outcome later on, right? So this is very important to differentiate. And I encourage you guys, if you're working on models for the fellows, always define your window of prediction, and that cannot have overlap with the time you are evaluating the outcome, right? The outcome is subsequent to your window of prediction. Now that's the interesting thing, right? Like always between the window of prediction and the outcome, is there enough time to intervene? And what's that intervention, right? So that's the critique to a lot of the dynamic models of AKI. Okay, you tell me AKI is going to happen in 12 hours. Can I do something tonight that is going to change that outcome? My argument is that you can always do something that perhaps you were not paying attention to, like maybe it could be a stop in that PPI or something else.
Perfect. Thank you again for that wonderful overview of the topic and coming up bright and early for presenting to us. So we'll be putting, for those who missed any part of it, this will be available on our YouTube channel, and you will get a survey to send some evaluations and feedback for us. Thank you again, Javier.
Take care, guys. A pleasure.
Thanks.
Bye-bye.
Take care.
Bye, Ed. Bye, Swap.
Bye-bye.